All right, let's jump right into this explainer. Today, we're unpacking a really fascinating timeline, the evolution of homeopathic prophylaxis. We're going to look at how a practice that was born way back in the 19th century holds up when evaluated against today's incredibly strict, evidence-based scientific standards. It's a deep dive into where history meets modern scrutiny, and we'll explore what that actually means for both practitioners and patients navigating healthcare right now.
So let's kick things off with a pretty provocative question from our sources. Can 19th century observational medicine safely intersect with modern evidence-based public health? I mean, how do we responsibly evaluate historical medical traditions using today's uncompromising scientific and ethical standards? It's a massive challenge, honestly. You have to balance a rich historical record with the absolute non-negotiable necessity of patient safety.
To figure that out, we're going to follow a clear path today. We'll start with the historical origins of prophylaxis, explore the genus epidemicus concept, move into appraising the modern evidence, and finally, we'll tackle ethics, vaccines, and safety.
Okay, Section 1, Historical Origins of Prophylaxis. Let's look at how this all began.
Before we get too deep, we really need to define our terms. Prophylaxis is action taken to prevent a disease before it even occurs, and this is completely distinct from treating early symptoms. Why does this distinction matter so much? Well, because to claim a true prophylactic effect, public health science requires a measurable reduction in disease occurrence across an entire population. It isn't just about individual clinical care after someone is already feeling sick.
The foundation of this entire practice actually traces back to Samuel Hahnemann's 19th century accounts of scarlet fever and his use of the remedy belladonna. Now, carefully observing epidemics was incredibly groundbreaking at the time, for sure. But the sources highlight a really critical caveat for modern applications. Anecdote is simply not proof.
The sources contrast these historical accounts directly with modern evidence. Just think about the stark difference between a 19th century doctor guessing at a remedy based on contextual narratives and very limited diagnostic tools versus today's massive data-driven requirements. Modern evidence demands clearly defined populations, strict laboratory case definitions, and rigorous bias control. Those early reports, they were fantastic for generating hypotheses, but they absolutely cannot independently establish modern public health policy.
Moving right along to Section 2, the genus epidemicus concept.
Historically, during outbreaks, practitioners relied on a concept called genus epidemicus. Basically, this is a collective case picture derived from several well-documented outbreak cases. It wasn't just assumed right out of the gate. Practitioners actually compared cases to find unusual shared features. The whole key was separating common non-specific symptoms, like a fever, which, let's be real, doesn't differentiate much, from truly unusual collective characteristics. That's how they defined a potential remedy for a specific outbreak.
But when you compare a genus epidemicus to an evidence-based prevention program, the differences are huge. A genus epidemicus relies on a collective symptom pattern built from observed cases to help narrow down clinical choices in the middle of an evolving outbreak. An evidence-based prevention program, on the other hand, relies on measured effectiveness, integrated surveillance, logistics, and official public health guidance. They are vastly different tools designed for vastly different purposes.
Which brings us to Section 3, Appraising the Modern Evidence. Let's get into the hard science.
If you want to critically evaluate any research claim today, the sources point straight to the PICO framework. P stands for population. Who exactly is at risk? I is for intervention. What exact remedy and dose were given? C is for comparator. Was there a placebo or an active control? And O is for outcome. The outcome metric is so critical here because laboratory-confirmed infections provide far, far higher certainty than subjective self-reported symptom checklists, which are notoriously prone to expectation bias.
And evaluating evidence doesn't stop just because you read an exciting conclusion. The sources show that practitioners must evaluate clinical trials against a strict risk of bias checklist. Was the participant sequence truly randomized, or did selection bias creep in? Were the patients and researchers properly blinded to prevent performance bias? Were missing data points balanced to avoid attrition bias? These structural flaws can act almost like a funhouse mirror, completely distorting research findings and making them look positive when they really aren't.
This leads into how modern science looks at the big picture. While a single positive trial might show a promising signal, it's honestly just a single data point. It can so easily be affected by chance or bias, and it absolutely needs replication. Comprehensive, systematic reviews, however, synthesize the total body of eligible evidence.
This reduces selective citation and publication bias, assessing the true consistency and quality of the data to guide our overall confidence.
And that leads us to our final part, Section 4, Ethics, Vaccines, and Safety.
Listen to this distinct clinical boundary laid out by the source material. Homeopathic preparations do not produce measurable antibody responses equivalent to conventional vaccines. Ethical communication protects patient safety, respects autonomy, and maintains professional integrity. This firmly establishes that homeopathic products operate fundamentally differently from conventional vaccines, which work via established immunological mechanisms evaluated by strict regulatory pathways.
So, where is the ethical dividing line drawn in actual clinical practice? Well, the sources outline that responsible practice dictates describing remedies accurately, stating evidence transparently, and supporting official immunization guidelines. Unsafe and misleading practice involves using prohibited terms like homeopathic vaccines, guaranteeing 100% protection, or discouraging conventional vaccination and providing false exemptions. There is no gray area here.
And these ethical rules aren't just suggestions. They are absolutely vital when dealing with vulnerable groups. We're talking about infants, pregnant people, older adults, and immunocompromised patients. These groups face much higher risks and require prompt referral for authorized, time-sensitive conventional preventive care. No alternative prophylactic claim should ever delay diagnostic testing or urgent medical care for anyone, but especially not for these populations.
So, practically speaking, how should a practitioner handle it when someone asks for an alternative to a vaccine? The sources outline a very specific 5-step safe response pathway. Step 1, assess the actual disease and exposure risk. Step 2, inform the patient on the evidence and the uncertainty clearly and honestly. Step 3, recommend official evidence-based preventative care. Step 4, carefully document consent and any referrals. And finally, Step 5, review the evolving symptoms and risks. This pathway prioritizes public safety and informed consent above all else.
Let's pull all of this together into a complete 5-step reasoning pathway that really ties this whole explainer together. First, define the disease and the claim. Second, appraise the design and bias of the research. Third, compare the total evidence through systematic reviews. Fourth, protect established prevention methods like vaccines. And fifth, communicate consent and the safety net clearly. Following this exact pathway ensures that alternative prophylaxis claims never, ever delay standard vaccination, testing, treatment, or urgent care.
As we wrap up this explainer, I want to leave you with a final, really provocative thought from our sources. How will you balance historical medical traditions with the non-negotiable ethical standards of modern public health? Keep this framework in the back of your mind the next time you're navigating healthcare options, reading a new study, or reviewing public health guidelines. Understanding exactly how to weigh evidence is quite literally the most powerful tool you have. Thanks so much for joining me for this explainer.